just want to say welcome to everyone as you're joining us. My name is Betsy Peelan. I'm the Executive Director of Hope for HIE, and tonight I am joined by two incredible professionals in the mouth space. So I want to introduce Nancy Kalamusa, who serves on our medical advisory board. She is a speech and language pathologist specializing in feeding and swallowing disorders, and works a ton with our population in the HIE community. And her colleague and great co-mouth treater, Dr. Scott Siegel, who I will ask you both to give a little bit more of an introduction than I'm giving, but Dr. Siegel is and I hope I get all this right, but you are a board certified oral-maxillofacial surgeon in pediatrics. You're a pediatrician and a pediatric dentist, right? All those things?
Close. I'm not a pediatrician,
Okay.
But I am a physician. I'm a surgeon, and I have an MD and a DDS.
Wonderful. I knew that there's everyone has those strings of amazing credentials at the end with all the letters, and I know that you have a bunch. So please, Nancy, why don't you give us a little bit of background of you, and we'll talk to Dr. Siegel in just a minute about his background as well.
So hello, everybody. Thanks for joining us. Again, like Betsy said, my name is Nancy. I am a pediatric feeding and swallowing specialist. I've dedicated my career to the evaluation and diagnosis and treatment of infants and children with feeding and swallowing issues. Although by education, it says I'm a speech language pathologist, which is true. I've never really worked with speech or language. It's primarily been medically based feeding and swallowing. So I know that a lot of parents will come and say, well, you're a speech therapist. Can you help us with speech? And I'm like, you don't want me doing that. So anyway, I was in the NICU for 15 years. I've been in the hospital systems for close to 25. I've been in this career for 33 years. Opened my private practice approximately 16 years ago, survived the pandemic, and we're still here treating anybody who has any kind of condition related to feeding and swallowing.
Wonderful. And Dr. Siegel.
All right, I'm Scott Siegel, and I'm one of I don't know what to say, one of Nancy's posse or whatnot. I've had the great fortune to work, very closely with Nancy. I don't know for how many years at this point, and I don't even remember how we got started together. But
me either.
I've been in this field of what we call, tethered oral tissues. This is going on my 21st year of in that field. I've been in private practice for 21 years this year. And I'm, as you said, an oral and maxillofacial surgeon. So I do surgery of the face, the jaws, the mouth, teeth, taking teeth out. I have a dental degree, but I don't practice anything like that. I do more medical things than anything else. And a big specialty of mine is, treating oral dysfunction related to feeding, especially related to feeding in this population, the big population and neuroatypical, patients that we see together. And it's we do research in the area. We just had a nice article published on looking at some ways of doing ultrasound techniques of it for diagnosis and whatnot, and trying to get some objective data out there for physicians and other medical professionals who kind of doubt what we do. If you want to look at my rest of my bio, you can always look at my website as well. It's drscottsiegel.com.
Great. And we'll have information of yours and Nancy's in the comments after the event has concluded, for sure. Wonderful. And I just want to put this caveat out there. The internet today has been a little glitchy for all three of us. So if we cut out, we hope to cut back in.
Right.
But hopefully we're good to go now. So I guess let's just start at the beginning. What is a lip or tongue tie, and what are they? And then kind of talk through the impact they can have on speech, swallowing, and feeding, especially for, babies and kids who may struggle with, neurological conditions like HIE.
Okay. Well, I think we'll defer to Scott to give the clinical version of what oral tethers are, what they're made up of, and then I can kind of pair off with how they affect or impact speech, swallowing, feeding, etc.
Right. So basically, we have this broad term called tethered oral tissues, or TOTS, as it's the acronym for, and that kind of encompasses the terms people. So many people have heard of tongue tie, or that term, or lip ties and things like that. It's basically the little pieces of skin that hold or attach, like the tongue down to the floor of the mouth, or the lip to the gums. There are other areas in the mouth. I don't know if maybe I can share slides later to look at to show you what it looks like. But it's basically these little attachments that we look at and we assess, if they're impacting function, if they're impacting feeding, if they're impacting other things for function. We talk about potentially releasing these little tethers or little bands or ties to help improve function. And as far as, I can talk about the anatomy, but the anatomy is just one piece of the puzzle. We really kind of look at function. And when we talk about assessing these things, it really is kind of, I depend on Nancy, 100% to tell me, I think this needs to be, addressed or whatnot. It's not just how it looks, but how is this, child or baby functioning?
Right. So I'm going to pair off of that. I think in the age of social media and Facebook groups, Instagram, etc., we have a lot of parents who are sharing, pictures of their infants or their children, and they're flipping up the lip and asking, is this a lip tie? Is this a tongue tie, etc. I just want to make it known that it is extremely important to have an assessment done by somebody skilled in this area, who is skilled in understanding how those restrictions affect or impact the way that the oral cavity kind of integrates with each other and the musculature that's responsible for feeding and swallowing. I think too often I'm seeing these groups popping up, and parents are getting anecdotal information. They're getting information from other parents, which is great for support. However, clinical diagnosis is really about how the function is being impacted. And that can only be assessed by someone who's skilled in the ability to really make that diagnosis. So it comes with looking at all of the oral musculature, the face, the lips, the tongue, different aspects of how these sort of interact with one another in order to support feeding, whether it's breastfeeding, bottle feeding, cup drinking, spoon feeding. It can be at any point throughout the lifespan that we see that these small tethers or these sort of banded tissue can really cause what we term as compensation, right? So we look at how the infant or the child is sort of at rest. So we know whether or not they have the ability to have symmetry of movement, if they're able to utilize all the muscles to kind of create what we are looking for, which is a labial seal. That's our first indication. We need to make sure that the lips are functioning. They're the first step in digestion. They're the first step in making sure our oral health is adequate, the ability to feed, the ability to suck, the ability to move our tongue. If we have our lips apart for any reason, whether it's because our tongue is protruding forward or because our jaw is weak, or we have some facial weakness where we kind of have this open mouth posture, that will affect how the tongue rests in the mouth, how we swallow, etc. So I always like to do this kind of little exercise with my families when I'm trying to explain why the lips are so important. And we can all do it now. And basically it's just, if you leave your mouth somewhat askew, slightly open, don't close it, and try to swallow. And you can feel the impact of how much you need these muscles within the neck, within the chest, within the back of the neck, within the face, in order to make that swallow happen. So now if you think about how frequently a child needs to swallow while they're feeding, if we talk about suck, swallow, breathe coordination, you're talking every 3 seconds in an infant that's supposed to occur. But if we're not getting an adequate seal because we have a tether in any of these places, now we're looking at compensation, and we look at what that affects, how the feeding becomes. sort of dysfunctional, right? So I think I think I'm getting ahead of myself, but when we are trying to assess, most often the parents are coming here because either their children were doing well when they were feeding initially, and then they stopped or started to kind of pair off of feeding, whether they're losing weight, whether they're unable to meet the volume needs, whether they're getting gassy, or any of those things that come along with it, these comorbid conditions. And quite frequently, we see that the pediatricians are like, they're colicky, they're gassy, they have reflux, which all could be true. But if we talk about colic in a general term, it's just a general term where there's other conditions that are actually causing it. They just don't know exactly what's causing it, so they give it this generalization of colic. And that's what we see a lot in our typical population. In our neuroatypical population, we see these children really struggling because of what actually occurred for them during the birth process, how their neurological systems kind of shut down or were impaired during the birth process or after. And then the actual interventions that are used in the NICU that sort of impact that soft tissue, right? So if we think about babies who in the HIE population, we know that some or most have been intubated for some period of time, correct? And we know that that tubing within their mouth can cause the palatal junctures to not form appropriately, right? So if we're having these tubes in for a prolonged period of time, I also believe, and there's no studies yet on this, I believe that there is also an impact to the soft tissue. If we're having this tube coming in and resting upon the tongue, well, the tongue then can't rise to meet that palate. And we need that tongue to rise to meet that palate so it can create this concave shape, right? So if that tube is in the way, then the tongue is going to have to migrate closer to the floor of the mouth, or it's going to have to do this kind of cupping shape, or this whale tail, we like to call it in our world. So when you see a baby's tongue and it's kind of like this C shape in the beginning, the only way that they can move that tongue during that period is in and out, right? So if this tube is there, we're only going to be moving the tongue from the front of the mouth to the back of the mouth. Why is that detrimental for a child? Because when we're going to breastfeed or when we're going to stick a nipple in for actual oral feedings, we need that tongue to be coming up to meet the nipple so it can extract the fluid. If it can't rise to meet that, then they're relying on suction. But remember, if we had the tube in our mouth, our jaws are now conditioned to be open, and we have this open mouth resting posture. So all of these things contribute to poor feeding. But what we need to look at is where in this sort of progression of intervention can we do a better job at making sure that these bands of tissue aren't our causal factors for our children failing to feed in the NICU. So it isn't just the intervention. We need to make sure that the oral anatomy is in good condition and is reasonable to be able to feed, because so often they're so quick to say, okay, we tried to bottle feed, they can't bottle feed, or they're sucking on a pacifier, they do well on that, but the minute that you put any kind of fluid or introduce any kind of fluid, they fall apart. And what happens with that is you're setting them on a medical trajectory of having tube feedings, whether it's NG feeds or G tube feeds, the like. So we need somebody in that NICU, we need people to really be looking at, are these restrictions sort of contributing to why these children are failing? It's not just the neurological condition. Is there other anatomical issues that we need to really take a good, long, hard look at? Sorry, that was really windy.
Makes so much sense though, but
no, it's really good.
These algorithms from the get-go, because by the time we see a lot of these kids, they've been set down this path of failure, and it's really, they fail to diagnose certain issues up front, And just like you said, it starts in that NICU, and if they're not getting that foundation there, we just see it just kind of fall apart pretty quickly once they get out.
Right. I think another thing too is when we're talking about intervention, it's not just the physical properties of tubes, orogastric tubes, intubation. It's also the style of taping. I mean, so many times I see when I was in the NICU, this was one of my biggest pet peeves was we don't need to be taping all of the muscles of the face down to hold a tube in place. And we don't need to have it in the center. You can move it to the side. You can alternate this. You can do things that preserve the oral function. And I think so often that we're and not that this is a bad thing. I don't want to, anybody to get upset. We're worried about medical stability, which is absolutely the number one. We need to make sure that the kids are medically stable. However, we have to do a better job that we're not having these fallouts because we're worried about medically stabilizing, because these children have to function. Once you medically stabilize them, they need to function once they're discharged. And you can't just be like, okay, well, now you're discharged. And then they fall in mine and Scott's lap. And we have to be the ones who say, I don't know why we went for a tube so soon because we have these oral restrictions. If we got you sooner, we could have helped. I'm not saying avoid tube feeding, but we could have helped to preserve the oral function.
Yeah, those are such great points. And I mean, we obviously see this all the time. Like I said, feeding and swallowing is probably one of the top things that are discussed, especially for our new families in the first year, because you're either, like you had said, you're either coming home and it's sort of working, or you hit a plateau and then you go, okay, either they, really get the hang of it and things go off to the races and you're doing better, either in combination of therapy or on their own, or they're, if they are sent home orally feeding, they're potentially plateauing out several months after, things are getting, requirements for nutrition get bigger as they get bigger, so that's,
right.
That is definitely a question. And then we have families that are, that are several years out where they might've had a significant, maybe they've had a few months of back-to-back admissions or, illness or seizures or, things like that. And they're having a ton of feeding difficulties then, that's really impacting our kids. So yeah, it just definitely varies so much, in our community.
And I think that, when we talk about oral restrictions in this population, I don't want to have anybody misconstrue what the message is. It doesn't mean that releasing these restrictions is an automatic fix. And that's in any of the population, neurotypical, atypical. The problem is that, again, we go back to anecdotal information where you believe that somebody with a laser, not Scott, because he's not that guy, but there's a lot of people who are becoming, purchasing the equipment, starting up this sort of practice without a team approach. And it's important, if not absolutely critical, that there's a speech pathologist who's savvy in this, as well as your provider, whether it's an ENT or a dentist or an oral-maxillofacial surgeon. You need an IBCLC if you're breastfeeding. You need body work for tension. You need PT for torticollis. There's so many conditions that are the result of having these ties. And I think we have to talk about where this all starts. Like, this has been, if we talk about embryology, right, we know that these tethers have essentially been there since the ninth to 11th week. They're developing, the tongue is developing, and this piece of collagen is already developing. So their sucking patterns are sort of laid in the womb, right? So if we already have this sort of restriction starting, they already are coming out with sort of this behind the eight ball. So because babies are designed well, and they have these small mouths and they have adipose tissue on the cheeks, and the tongue just really needs to be in and out for this sort of nutritive suck, that's where we see the kids do okay for a couple of weeks. And then as the oral cavity starts to grow, and the responsibility of the oral musculature becomes more volitional, that's when we start to see the kids fall apart and where these restrictions start to rear their ugly heads, right? But in the case of a child who has HIE, we may not see that for weeks or months because either they're not getting the care in the NICU with a feeding specialist, or they're taking so long once they get discharged to get to somebody who can actually help them feed. So whether it's finding the right person to administer the feeding and swallowing, therapy, or whether that person is just unaware, you need a good team approach, and you need the pediatricians to start or stop dismissing the fact that this can be contributing in their feeding journey, right? So often we hear a lot of parents say, "Oh, my pediatrician evaluated and said he doesn't have a tongue tie, or he can stick his tongue out," and we know a lot in this population that forward resting posture is one of the neurological signs or symptoms. But that doesn't necessarily mean that they can use it functionally. So just because you can have your tongue cross over the lips does not mean that that is indicative of not having an oral restriction. Again, it's the way in which that wave formation or the elevation, the mid-rise of the tongue to the palate is what we need for appropriate speech and feeding.
Yeah, that's
okay, Scott, jump in.
Yeah, no, I it's like I just kind of say ditto. But when I speak to the families, and it doesn't matter, neurotypical versus atypical, we always say, this is not the silver bullet or magic bullet. It's a piece of a puzzle. And I talk about, this is a potential roadblock for your child that we can safely remove, with minimal risk, minimal complication, in conjunction, just as an adjunct to the therapy. It really helps, the feeding therapist do their work and do their magic, as we say. We cut these tethers or release the tension, this fascia tension and whatnot, to allow that tongue to elevate. And that's one of the things that we had just, published, was looking at dysphagia. We're looking at, airway protective mechanisms and feeding and swallowing and, normal feeding, breast and bottle feeding, and looking at it across the all forms. And we see that tongue elevation is the big key. So trying to get that education out to the pediatricians, where they say you can stick your tongue out, you're gaining weight, they're okay. Or they have something called a mild tie. In our areas of specialty, we say there's really no such thing as a mild tie. We say it's like being mildly pregnant to somebody. If your child has an issue that is potentially caused by this restriction, it's 100% to them. It's severe to them, so, and then they just go on based on appearance. That's why I try to get away from looking at these things we talk about the social media thing and people sending you pictures, is this a tie and whatnot. It's like, I need to have that functional assessment, by a very qualified, what we call TOTS savvy and educated feeding therapist, or IBCLC, somebody like a Nancy who's got a lot of experience, because you can't just take a weekend course and get this, and you can't just buy a laser from a laser company after a weekend course or laser to do this or do it well.
Did you freeze?
You just froze the last sentence and a half, maybe.
I don't know what I said but I was saying that, you can't just take a weekend course. You can't just, go to a laser conference and buy a laser and expect to come out, laser blazing and get great success with this stuff.
Right. 100% agree.
So when we talk about, I think, a really helpful overview of the impact that these can have on, speech and swallowing and feeding. And so, and you talked a little bit about identification and making sure that it's done by, kind of this comprehensive team approach. Can you also talk about what, we're having a lot of questions that are popping in of what kind of professional, because we're having different experiences, as you might imagine, of people who go to their pediatrician, people that are going to the speech pathologist, people that are getting referrals to ENT, there are many different roads to mitigating these. Can you talk through that a little bit about what your advice would be for these families?
Hmm. That's a big question. It's a lot of confusion. It's confusing for me. I get confused on who I'm working with and who's qualified or putting out their qualifications saying that they are qualified. So you really have to do due diligence, and I would say one positive aspect of the social media area is you can get a lot of advice and guidance from either parents or whatnot in your local area. There are tongue tie groups, there's feeding groups, there's lactation, speech. So I come from it at a different angle than maybe Nancy will, but and I get tagged a lot on these social media groups, and they've been okay for certain guidance to try to get to the right professional, whether it's a lactation consultant, whether it's a feeding therapist, speech therapist, and then trying to get to the right release provider, who's either in a lot of these social media groups will have what we call preferred providers, or there's a couple of national people that are trying to get preferred provider networks out there for people. And it's not about bashing pediatricians or whatnot. It's just not part of the education at this point. I'm a fellow of the American Academy of Pediatrics, and we've been trying to work with that group and trying to get this integrated into medical education, trying to get it integrated into dental education, so that there's an understanding, from the medical community. As much as you talk about, Nancy can talk about this speech and feeding education as well. But it's a very frustrating and confusing thing.
Right. I have to second that. So often it's, for lack of a better explanation, it's really through trial and error that we're building our teams out here and even nationally. So, when Scott speaks to due diligence, it's important to have the conversations with these, therapists or providers, because I'm getting emails and tagged in things as well all over the country and globally, like, who can I go to? So, I think it's important that you understand, the two providers that typically do this would be someone like Scott, who is a pediatric dentist and oral-maxillofacial surgeon. And then there's ENTs that do this as well. We talk about laser revision or release versus scissor release, where a lot of practitioners are still, they're good at their job and they're good at their craft, and they're doing scissor releases, which are good. But a lot, I'm going to say in this population, I find it hard pressed to find someone to do a thorough release or a complete release on my kids who have neurological conditions. So I always defer to using the laser, because I find that for these kids, it's a lot easier for them in the pain aspect and also for the bleeding aspect. If we're talking about kids who are having problems swallowing, we certainly don't need them having, this consistent amount of blood being pulled in their mouth, because they're not going to be able to manage that. And that when anything bleeds in the mouth, the minute it hits saliva, it looks like it's a liter versus a tablespoon. So we get panicked, right? So I tend to always defer to the laser, especially for the kids who are in my HIE population. Speaking to that, I think it's important for our group, for the group here, that you need a skilled feeding and swallowing therapist who understands why we're releasing. Okay, so meaning what are the benefits for releasing this and why we wouldn't release it. Okay, so addressing this fact is, if we don't see that there's underlying movement, meaning that the tongue is essentially stuck to the floor of the mouth, and when we evaluate, we try to see if there's movement either to the sides, if they can lift it. If we're not getting that neurological drive to the tongue, the muscle, then just releasing this is not going to do anything. It's just going to heal right back where it was. We need some range of motion of that tongue. So I know that a lot of my community will come here and say, will you release so-and-so's tongue? I want my son or daughter to have their tongue released. But the critical factor in all of this is I need to make sure that there's going to be movement once we do that. Okay. And if we're not going to get that movement, we're essentially setting this child up for more failure, because now we're going to have scar tissue that's essentially going to anchor that tongue even further, or the lip. And so that's not going to be beneficial at all. And in fact, you're going to make things worse. So we see that in other situations, not ours, but in other situations where parents have come and said, we had it released, you know, our speech therapist in this area told us we should go have it released, and we did. And now we're noticing more drooling, they're coughing and choking more. Well, that wouldn't be the candidate, right? We need to have at least an intact, somewhat intact system so that we can work with it. So if we don't have the underlying movements or those sort of foundational skills, it wouldn't be something that I would rush to do. However, likewise, if I have a child that comes to me and I see that we're not going to be able to make great gains if we don't address this first. And Scott knows I will call him and be like, I'm going to send you a picture. Tell me what you think. Do you think it'll be beneficial? Where do you think we should start the process? Should we do the tongue? Should we do the lip? Do we do the buckles, you know, the cheek ties? And he will give great advice and say, well, let me assess them, and then we'll see what the impact is. And then if it's necessary, we'll do it. And most often it's the right call, because they come back and I'm able to do an efficient job in getting the oral musculature to work together to make the feeding better, or at least the swallowing.
Gosh, I think you brought up such amazing points and answered so many people's questions that have been popping in. I did want to ask a point of clarification. Someone had asked the question of laser versus cold steel. Is that what you're talking, like the scissor, is that the cold steel? I just wanted to make sure that was
right.
Okay.
Yeah. I mean, there is another approach, the diode, right, which is different. I don't know many professionals that use a lot of diode, sort of, but I think when you're talking hard steel, you're talking about scissors, right, Scott?
Yeah, it's basically scissors, scalpel. That's what we term cold steel.
Okay. Yeah, just that's so helpful, because that was a question that came in, and I
the traditional way of doing it.
Got it.
I you know, and again, we talk about, you know, the benefits of each of them. There's many good scissor providers. One of my mentor was an amazing scissor provider, but we talk about this population, and you talk about the bleeding aspect is really what we're trying to deal with. If you have someone who's at an aspiration risk or struggling to handle secretions to begin with, you know, it's so much faster, more efficient, you know, less pain, you know, when we compare side by side.
And I think, I'm sorry, I wanted to jump into this because it's been boiling in my head. I think we need to explain the difference between when we say tongue tie, right? Anterior versus posterior, because what we're essentially discussing right now is a posterior tongue tie. The tongue is restricted to the floor of the mouth with a thick banding of tissue or collagen to the floor of the mouth. There's also another tie that occurs in the front of the tongue, which kind of gives it this sweetheart look, this kind of concave or humped look to the tongue when they stick it forward. The anterior tie is usually taken care of with a scissor. I mean, a lot of the pediatricians used to do it with a scissor and just cut that anterior tie. However, we're knowing through research and through, you know, actively sharing our information with all of the professionals is that if there's typically an anterior tie, most often there's a posterior tie, correct?
Yes.
We would see that tie even further back. So I think it's important to differentiate between tongue tie in the traditional sense and posterior tongue tie, which is what we're talking about, the impact in feeding and swallowing.
Great. And I know you touched on this, and I wanted to kind of bring up this question as well. So when you talk about the actual functionality of being able to move and who would be a good candidate currently and who might not be, I know, you know, going through my own son's journey of some feeding issues, and we worked with an OT for his, and, you know, we're very successful with, you know, helping him along with his feeding. But I know, so I'm guessing that this is not necessarily a forever thing, right? Like if someone, it could just be, you know, kids are going to potentially develop, better feeding skills with that, speech pathologist or OT or whoever they're working with, to improve their oral motor capabilities. And so, I know that we have a lot of families that are looking at, when their kids are little and saying maybe, okay, they're not a great candidate right now. And again, as Scott said before, this is a piece of the puzzle, right? There's multifacets to this. So I just wanted to, kind of bring that out as a point of clarification, because we do have a lot of families whose kids I know are like 3 and 4 and 5. And, I can think of the other people in our community whose, kids have come to see you in particular, Nancy. And then, they're like 6, 7, 8 years old, and where they might not have been ready for something like that revision earlier, but then, we're ready later.
Right. And it's timing is everything. The timing of the release is critical in both populations, neurotypical, neuroatypical, infancy, toddlerhood, etc. I think it's important to note that, there is some level of cognition that's necessary as they get older, because it's not just working on, oral motor exercises with them. You need an oral myofunctional therapist. And one of the criteria is that you have to be able to imitate. So you need a certain level of cognition in order for that to occur. So imitation of those motor movements and being able to place, small pieces of rubber band, et cetera, different tools I'm not an oral myofunctional therapist because I primarily work with infants or, the neurologically impaired population. But many of my colleagues are fantastic oral myofunctional therapists. And, we're trying to do a better job as a community of professionals to delineate who is the appropriate person to see, right? So if we're talking about feeding and swallowing in 3 and under, right, then it would probably be a speech pathologist or an occupational therapist who is skilled in this arena, okay? It would need to be somebody who understands anatomy and physiology and how it, is impacted by this tie, or what are your goals going to be so that it does make that functioning better. And so often I hear from many parents is that I'll get these emails saying that, my OT said I should get this released. And I said, okay, that's great, but what's the plan following that? And that's where we have our sort of disconnect. So we have a lot of professionals who are referring for this, which is great that you've identified it, but now what are you going to do to remediate it? How are you going to make it better for this child to feed? And that is where I'm finding it to be a very difficult area, because it's not just about how the oral cavity is functioning, it's how is it functioning with food, with liquid? How are they able to make a definitive impact in making this better for the child? That's the critical part. That's the part that's missing in a lot of these plans.
100%, 100%. There's so many times when I've gotten, what I think is a baby or patient that's ready because parents said they've been working with their speech or feeding therapist and whatnot. They said they're ready to go. And then all of a sudden we do the procedure and the wheels come off the bus. Everything's going backwards because there was no real pre-op prep and aftercare, regimen or protocol or something in place. So that's of utmost importance. And having that team and an experienced team is really, you circle back to that. And, knowing where to get that, your association is helpful for that too, because you can help direct this population to the right people. We try to get those of us in the field, we kind of know who is who in each of the states or whatnot. And we do have local networks that we know who is, so we are probably good resources to reach out to, versus just trying to figure it out on your own. But it's really, you can't, hit that over your head. I don't know how, you just really can't do it enough, because you want to, first of all, do no harm. And, we see a lot of harm being done. And I can't say, even in my own practice, I've had many cases over the years that you think you're doing a great thing and all of a sudden they're backwards, you're sliding backwards. So it's knowing when not to, do a surgical procedure is maybe even more important than just doing it, you know?
Right.
Yeah, that discernment is definitely a piece that I think perhaps our families might struggle with sometimes, because everyone wants to do all the things to try to help their kids the best, right? I mean, no one wants their kids to, you know, to struggle with things, obviously. But, you know, I think a lot of times also it's difficult for people to take that news, whatever it is, whether it's this or something else, of no, this is not going to help your child either at this time, or, you know, they're not a good candidate because of X, Y, and Z. And then kind of, you know, having to process that as a parent of, wow, I really thought this might be something that helps. And kind of that moment where that doesn't feel good.
Right. And you're right. And it's a difficult moment. And there's been times where I've been faced with that, where I've identified that is absolutely a restriction that is causing a lot of the problems. However, you know, releasing it is not going to make it better per se. And in fact, we may, like Scott said, you know, the wheels coming off the bus, it's true. We can create more issues if we attack it that way. And I say attack it because I've seen, you know, there are dentists and ENTs who are like, all right, we'll do it because you think this is going to make it better for your child. And because, you know, they're berated, you know, sort of hammered down into the situation. And there are physicians who will do it. But it doesn't necessarily mean that that was the right step. And unfortunately, this is where we go back to education, training, who are the appropriate people. And I know I keep saying the same thing over and over again without sort of, you know, a solution. But, you know, you have to understand too, in our professional world, just like you said, you want everything to happen for your child, if that could be a positive in their world. However, it's very difficult for us to do research, because in order to do research, we have to get the same child and say, no, you can't have it. And yes, you can have it. What parent is going to agree to that? There's going to be very little that'll sign up for that study, because if I've identified that that is the problem, they're going to be like, do it. But I have to say no, because I want to study this child. No one's going to sign. So you see how difficult it is in so many factions that we can't get good data to try and help lay the foundation so that we can educate the families. We're trying, but it's very hard.
Well, and that's just such an interesting thing. And we can talk about this offline too, just because, you know, as Hope for HI has been getting more involved in different facets of, you know, the medical community and research community in particular, you know, through NIH, there's this PCORI program where it's not like the double blind, you know, studies of traditional NIH, and it is really involving patient and families. Everyone's at the same table developing these together. So, you know, it's a newer model of funding and of research. And I just wonder if there's, you know, potentially opportunity there, you know, that we can look at.
That's great.
Yeah, I think that's a great way to look at this, because it's like you said, you know, and we get it. I get it all the time from, you know, my medical colleagues, like, this, you're not giving me studies. I need to see studies. Like, we're limited. We can't do these studies in this population, just like Nancy said. It's like, we can't, you know, deprive somebody of a treatment that's really going to help them, and, you know, put them into different cohorts that way. It just doesn't work. So coming up with these other, you know, ways of doing the research, and if NIH, you know, can move forward with that, I think it's a great way to do that.
Yeah, it's just an interesting, I've just been a part of, you know, a couple of these now, and it's really nice to see, because you're really in it together and develop, it's patient and family-centered care through research. It's, you know.
Well, you know, so often we get hung up on evidence-based practice, right? And if I hear it 20,000 times a day, where's the evidence-based, you know, okay, so here's my evidence base. And this is what I say to my families. Your child wasn't feeding. We did this procedure. We did this therapy. Your child's feeding better. There's your study. And I say this to the doctors all the time. It's yes, evidence-based practice is extremely important. But when you're talking about something that's unto someone's own, right? So even if we talk about, I'm going to digress for a second. If you talk about, they're trying to do studies about the strength of the tongue and the rise of the tongue. And there's, you know, tonguometers and all of these things to get these, you know, numbers. And we own a lot of this stuff. However, clinically, that data is not relevant. It's like using surface EMG. It's your muscles and how much effort your muscles put out. So how can I take your child and say, yes, his tongue rose to the 10th level, but your child didn't, so we're going to do that. We're going to do the release on him. But it could be that that strength of tongue, the neurological drive to that muscle is better, whereas the other one is not because of the tether. And this is where we kind of all get sort of encapsulated into this research driven, which is important, but evidence-based practice when we're looking at infants who are failing to feed. And what we're faced with is we're going to put them on a medical trajectory they don't belong on, which so often Scott and I talk about this all the time. They wind up with feeding tubes. And then I see these babies coming in with alternate means of nutrition, whether it's G tube or NG tube. And the whole time it was because there was a tether. There was no way for this baby to be successful. It failed because someone didn't do their job. And that's not okay. Like, that's not okay in our world. So when, you know, even it doesn't matter just across the lifespan, if you're failing and there's other things that can sort of promote better oral health, better breathing, you know, reduce reflux. And I'm not saying that these are all causal factors related to the tongue tie, but we have seen the kids do much better once we release that tension and they're able to properly rest their tongue in the position that it was naturally designed to do.
Exactly. You know, we always talk about this evidence-based, getting back to that, you know, and we talk about experience and we talk about experience-based practice and, you know, best practices and, you know, but again, each child is so different, or each, you know, baby is so different. They're unique. They're just like you're talking about. We can't just look at a number. We're not looking at a type 1 tongue tie versus this, or how much can they elevate. Those are great things, but you really want to understand what's going on with the function, what's going on, you know, with their sensory aspect. You know, are they feeling their tongue get up to the roof of the mouth, or can they not feel that? Or there's so many different little pieces of the puzzle that you look at all of this in the whole big picture, and we see so much of a failure to diagnose. And that's, you know, the biggest thing that, you know, coming up from the ranks in the fields of medicine and pediatrics, and, you know, or the NICUs or PICUs or wherever these kids are coming from, there's a uniform failure to diagnose in the medical community. And it was a big lecture, you know, many years ago at one of our big tongue tie conferences by a well-known pediatrician, Jim Murphy, who's also an IBCLC. And he gave this very eloquent lecture on failure to diagnose and how we're failing, you know, these families in our field of medicine and dentistry or whatnot. You know, we really need to kind of change the whole way we approach this. And it's so frustrating, but we're all in it together. There's been a lot of progress being made. It's slow. Yes. It's an uphill battle, but having these conversations, you know, in each of these arenas really helps stimulate more. And a lot of the families wind up going back to the pediatricians. They go back saying, you know, this helped my family, helped my child. Please, you know, maybe pay attention, and maybe you have a pediatrician that might be open-minded enough to think out of the box and move forward that way.
Absolutely. Yeah. I mean, you know, we're always looking at that. That's one of the biggest, I think, benefits of conversations like this is, you know, a lot of times in these situations, we don't even know as parents, what questions to ask, right? So this is empowering families of just to ask the question. And whether they end up being a good candidate or not an appropriate candidate for something, at least we're having these conversations and they're feeling empowered with knowledge and that these things are out there. They have a better understanding of the role of, you know, what, you know, a provider should be doing, or, you know, or that someone exists that specializes in something like this, you know, it's like awareness for that. So I want to thank you both for coming on today. We have a few questions that are coming in. I think we covered like our basics of our agenda this evening. You know, this has just been so amazing. I really appreciate you both coming on and sharing your expertise. So I do have a few questions that have come in. Some are directly related to tongue and lip ties, and some are just some general SLP questions as well. Okay. So I'm going to throw them at you. I think we have about 3 or 4, and then we'll call it a night. Is a suck reflex normal for an HIE toddler who has never eaten orally to still have?
That's a tough one. That's a tough one. So if you're talking about them, I think I need more of a description of what they're saying is the suck reflex. Are they talking about them sucking on their tongue, sucking on their fingers, sucking in general?
I think just sucking in general. She said my son would still suckle 24/7.
Yeah. So are they working, if they're working with a speech pathologist, that can be migrated over to a functional sucking pattern. You need somebody to work with in order to transition that over. It's not necessarily normal to have a suckling reflex at this age. But again, the intervention is important, because if we're getting that movement, then what are we looking for? Is it a sensory based issue? Are they looking for this sort of self-satisfying soothing? Are they looking for these muscles to integrate in the sensory system to sort of, I guess, be the primary foundation for introducing something that they can manage orally? Does the child aspirate? I mean, that's an important question, because, when people come at me with, and with all due respect, when you make a broad generalization, it's hard to do that because there's so many other factors that are related to sucking reflex, right? So we need to know, like, kind of the backstory. If they're aspirating, then we're certainly not going to be introducing anything, but we need to figure out why this is happening, because it shouldn't be there at this point.
Well, and those are great questions that they can bring up with their provider as well, right? Like, and might not have thought of without this conversation. So thank you for that, Nancy. The next question is, does a tongue tie have an impact on the function of the vocal cords?
That's interesting. I'm going to say it potentially could, only because of tension. If we talk about that little exercise I did in the beginning, if we're talking about sort of clavicular tension or laryngeal tension, because our tongue is anchored to the floor of our mouth, that tension that's created there over time could potentially affect it. It also could be affected by the way in which they're managing their secretions. Are their secretions pooling? Is that affecting? Are they having reflux that is getting up into the laryngeal area? That could be affecting the vocal cords. Is the tongue tie creating more problems with the reflux? So again, I hate to say this, but there's a lot of other factors that go into it. It's not just a one scripted answer. There definitely could be contributing factors to having some sort of vocal cord dysfunction, or even just impairment with the vocal cords.
Awesome. And then the last question that we'll talk about is in regards to different ties or tots, as I've learned this evening, and the impact on speech. Is it more that it can cause a speech delay or a speech impairment, like with articulation issues, or both?
Again, great question. So, if we're talking about language and we're talking about the language centers of the brain, I don't necessarily think that the tongue tie has the impairment on what the functionality of the brain is, right? So receptive expressive language is not necessarily going to be, this won't be the causal factor for having that sort of language delay. But if we're having a speech delay in terms of pronunciation, articulation, things like that, due to the tether on the floor of the mouth, that can definitely delay the rapidity of how fast someone speaks, how they get their message out. Oftentimes Scott and I have seen so many kids that have come in and been diagnosed with, global apraxia or apraxia of speech. And, we'll look at these kids and there isn't any global apraxia. There is difficulty creating the sounds or making the sounds appropriately, but they may also have this tongue tie because they can't make those sounds, right? So yes, that can contribute to speech issues. We're looking at that more. I think a lot of sort of basic level sort of entry questions is, what can it affect? So one of the things we look at is like your primary sounds like T, D, and L, but there's also bigger sounds like R that we're noticing in the older child that have been in speech forever, doing this same repetitive S, R, any of these things. Well, they're not going to be able to do this unless the jaw's moving along with the mouth and along with the tongue, right? And they're acting as one unit. So those R's are never going to come out appropriate. So you need to look at that to see if that's also a root cause as to why we're not making any progress in speech. And that's a big deal. We don't ask those questions. Why is my son working on turtle for 3 years and looking at pictures of turtles, and you're just sitting there going turtle, 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 and he can't make the sound? So look at the anatomy, look at the physiology. I always defer back to anatomy and physiology. It's always good to get a clear picture of what they're doing, and then you can build your plan on that. I hope that answered.
Yes, super helpful. Honestly, thank you so much. I know those are kind of like fastballs coming at you. You know, and like everything, it depends and it's complicated, right. And there's all these different factors that you need to look into. But I wanted to make sure that we just, kind of talk through, just at least to give people something to think about with that, of again, questions to bring back to their own team. And this has just been such a wonderful evening of Q&A with you guys. Thank you so much for sharing your amazing expertise and being so willing to do so. Like I said, this has been a topic that just continually comes up in our community. There's also, like you had addressed as well, there's all sorts of misinformation out there. We want to make sure that, we're getting vetted experts that are, coming in and giving people things to think about and talk about and really get a better understanding of what their children might be facing and how their mouths are constructed and how different things impact, the different systems in everything that's going on.
I will just add one last thing. I think Scott and I we're doing a better job in trying to manage the children with neurological conditions, right? So when we get this neuroatypical child, so often everybody's so concerned about everything else, like I said in the beginning, that we fail to kind of look at some primary causes of why things are sort of going south. We're doing a better job, I think, in terms of the identification, the management. We do intensives here, and when I see that the children have these, I immediately send to Scott because I know they're only here for a shortened duration. So I need to make the biggest impact as quickly as possible. And so do I think that that is appropriate in all scenarios, in all situations? No, but I don't have the luxury of having pre-release work, right? Because I'm only seeing them for a short period of time. So I've got to get in, do what I've got to do, make the changes as fast as possible, and then communicate with whoever's going to take that case over when they go back home. So it's important to have that conversation. And so often, we'll get, no disrespect to any speech pathologists or OTs or whatever, no one calls, no one, if you're struggling, contact the therapist who recommended the procedure. So maybe they can help you, because I can help you devise a plan that will be better suited to carry, to make a better effort or a better impact in what the whole reason why we did it to begin with.
Well, and I just want to point out too, we're in kind of this new era of telehealth too, where we can also as families advocate to get people on a call like this and say, hey, team, we want to make sure this handoff goes well, because if we're seeing so-and-so for this over here, we need to have this conversation and bring our providers together. And I think as parents, sometimes it's a communication skill set that, you have to work on. And you don't have to be aggressive about it, but you can be, confident in saying, this is, let's all come together about this issue with these team members. It's just like building a baseball team, and making sure people are talking, so that way you're getting a lot of people are traveling, they're using their insurance money, they're using personal pocket, you want to make sure that this value, everyone's coming together and are focused in the same, way.
100%. And I think a lot of times I'll liken it to, being a contractor on a project, right? There's a contractor for a reason, because you don't want the cabinet builder and the person who's installing your tile. You know, you want everybody to kind of orchestrate this plan to make a beautiful kitchen. But when it comes to advocating for our children, where there's this disconnect, like we feel like we're being aggressive or we're being assertive or being pushy. You know, I always say to my parents, who do you want to communicate? Like, who's going to take this over when you go back? Because if you're not going to have anybody to work with you, this is pointless. 2 weeks of doing this is not going to be okay for anybody. It's just going to put the baby or the child in an uncomfortable situation, and we're going to work with them to get sort of the foundational skills, and they're going to go home and not go any further. And that's not okay. So we again, you're right. We need to do a better job of communicating. And in telehealth, you know, it's very easy to set up, you know, a follow-up to be like, okay, here's my team, or here's part of my team. Or what should I ask my team? Because I went back and they were, you know, they're uneducated, or they're not sure where to start. So.
Right. And, you know, most everyone means very well and everyone wants the best for our kids. And that's, again, part of that team medicine approach too. So that's, you know, I think that's such a helpful hint to make sure that, you know, we as parents can sit down with, you know, if we're spending time, I mean, a lot of families are doing intensives and different things. It's like, you want to get what you just invested in time and money, and, you know, like, you're uprooting your life for, you know, potentially a couple of weeks at a time. Yeah, it makes sense to go back and say, hey, you know, I just did this. These are the things that we saw. And can we get, you know, on a call to make sure you guys are connecting, and that there's this conversation that you have for the benefit moving forward. So,
well, I think on the professional side too, everybody needs to put their egos aside. You know, every once in a while, people will get defensive, and I say it as a generality, not as a specific, but, you know, like, who are you to tell me how to handle my patient? Well, I'm not. What I'm doing is I'm offering a plan of care that I know has value based on what I've seen preliminarily and how this affected and how I'm going to change it. And I need you as part of this team to help carry through with these goals that I've, you know, skillfully designed to make it better for this family. But so often we hear people like, well, I took this course, I know this, I know that, which is fine, but we kind of have to let that go a little bit. You know, work is, like you said, work as a team. Doesn't matter if I'm in New Jersey, if you're in California and you took X, Y, and Z course, I can still help you. I may have little nuances of doing this for 33 years that might be able to help you. So. Absolutely.
So such great information and conversations. Scott, parting words as we're shutting this down.
Well, listen, you know, it's a journey. You know, the families are all on a journey. The professionals you're dealing with are on a journey. We're all kind of, you know, holding hands together and trying to do the best, you know, we can with what we know and the experience that we have at this point. So, you know, I think, you know, it was just a great talk tonight, just to kind of get things and hash things out, and, you know, not get so bogged down in what something looks like or whatnot, but understanding that there's a team, understanding that open communication and advocating for your family is really the thing that you need to do. If you're not able to do it, then you have to have somebody that can help you do that.
Absolutely. Thank you both so much. We are getting just flooded with thank yous from the audience. So thank you everyone who tuned in tonight. And we look forward to the next one. Our next topic next month is we're meeting with a panel of NICU nurses. So that'll be fun to talk through support. So again, I want to thank both of you for joining us tonight, and for everyone that has been tuning in. And this will be available afterwards in the video section. It'll also be posted all throughout our social media sites and on our website. So everyone have a wonderful evening, and thank you so much.
Thank you. Thank you, everybody.